I have to change. Hi. I always have to put my chair this way. We're just trying to get situated here because my chair just is too big. So I figured out I gotta be sideways. So welcome everybody to another episode of Bedlam Beyond Mental Illness. I like Beyond. I think we called it Behind, but I like Beyond. So that's what I'm saying.
Did we call it Behind?
I think so, but I'm not sure, to be quite honest.
We should figure that out.
Yeah, one day. We are your hosts, Randi-lee and Renata. And today I have done the research. Mm-hmm. And look at me saving trees and not having it printed out. Oh, big time now. Until I press a button and lose it all. But
shh, don't say that.
It's fine. It's totally fine. Just to follow up on something that somebody had asked us before, Discord. I have actually set up a Discord server. Still working out the details on how the heck to use it. Thank you to my kid. She totally helped me set it up. So we will have that info. Maybe next time we'll try to share and try and figure it all out. But it is coming, just like it was asked for. So it's totally coming. So we can all kind of chit chat and share and whatever there. Anywho's. I'll see. I told him I'm going to press buttons. I didn't even mean to press buttons.
Don't press any buttons.
Sorry. Today we were talking about something that I never knew even existed. And I was like, how did I not know this existed? And we have mentioned it already on the show. Insulin shock therapy.
Oh, yeah.
Yeah. Mm-hmm. I know we were going to do an episode of 2 weeks ago, but then Renata was sick. And then last week I was sick. So, yeah, it's been a while. Life. All right, so sources are Britannica.com, National Library of Medicine, and WebMD. All right, so first off, what the heck is it? Because
I don't think I've ever heard of it. Is it being used as a tool to control mental illness?
Yeah.
I've never heard.
Yep.
I've never heard of it.
I had never heard of it until it came up in some of our other research.
Right. Yeah. Really interesting.
Right. All right, so. It is a form of psychiatric treatment in which patients are given increasingly large doses of insulin to induce hyperglycemia with low blood sugar.
Hypo. Okay.
Yeah. Too much insulin. And a result of that would be a coma.
Yeah.
Mm-hmm. Which actually, that is how. Oh, no, he was hyper. So Andrew, my husband, when he found out he was diabetic, he should have been in diabetic coma, but he was hyperglycemic, not hypo. He wasn't low. He was high, like ridiculously high.
Geez.
Right.
Like my ex has diabetes and low blood sugar coma state. It's life threatening. So, okay.
But let's just induce it. That's fine.
Wow.
So it's based on the notion that hyperglycemia-induced coma could basically jolt patients out of psychosis.
Oh.
Yeah. If you're in a coma, when you come out, you'll be fine. Okay. So it was conceived in the 1920s by a Polish psychiatrist, who I'm going to totally say their name wrong, but Manfred Sakel, which I actually think that's what it said. But it probably has some kind of accent that I can't do, but Manfred Sakel. So what he actually did, how he stumbled upon this, because it was a complete stumble, which I think a lot of medical things are.
A lot of these things are, yeah.
Right? Like insulin as a whole. No, not insulin. That other one. I can't remember what it's called. It'll pop.
A med?
Yeah, it was a medication. But I can't remember. It was it's a vaccine that I stumbled upon. I don't know. Anyways. Anywho. So we accidentally administered too much insulin to a patient with a morphine addiction, and it triggered convulsions and coma. After the patient regained consciousness, the patient experienced an improvement in mental clarity and reduced symptoms of drug withdrawal. So he's like, all right, maybe this is worth a try here.
Okay, maybe, okay.
But it could have just been that.
Luck.
Like during the coma, he went through the withdrawal with, being unconscious. And then when he came out, he was fine.
So this doctor made that observation and then decided to test the hypothesis.
Yeah. So it led Sakel to conclude that insulin given in doses sufficient enough to induce a coma could potentially rid patients of mental health conditions. So then he started testing it with patients with schizophrenia. Right? So it started with a drug addict, and then went, let's try schizophrenics, because and this is going to sound horrible, guys, because our loony bins are just filled to the rim, right? And that's, if you go back in other episodes, we've talked about how mental institutions were there just to get people out of the community, and they were too full. They were just full of people that weren't actually getting help.
Right.
Yeah. So he began doing that in the late 1920s. So administering the drug in doses high enough to not only induce unconsciousness, but also sometimes trigger convulsions. He considered that to be a benefit. If you were convulsing, that was good. It meant it was working.
Wow.
Yeah.
Wow.
So in 1933 is when he published the results of his trials. So despite the lack of evidence to support the effectiveness or the safety of insulin shock therapy, the treatment quickly became popular and it was adopted by psychiatrists worldwide.
Wow, really?
Yeah.
Because they were so desperate to
treat these people.
To deal with.
Yeah. I think they were just desperate to have less people in the asylums because they were so overflowing.
Yeah, lessen the burden on the asylums.
Exactly. Yeah. Then you can keep the real bad ones there. Yeah.
Wow.
Yeah, they're awesome. So in 1939, it was being promoted by governmental public health bodies and favorably reported in the mainstream media. So the approach, which entailed almost daily injections, like it wasn't a one-time thing either.
Almost daily for how long does it?
I'm going to get there.
Okay.
To induce the unconsciousness that lasted an hour or more. Yeah, it wasn't a quick thing. It wasn't like you're in a coma, you're out. No. Multiple times for multiple hours. Yeah.
Okay, yikes.
So they would be brought back to the waking state with an injection of glucose, sugar. So it was repeated 6 days a week, not on Sundays, over the course of months.
Wow.
Mm-hmm. Some instances, a year. Mm-hmm. With steady increases in the insulin dose to produce deeper states of coma. Because the deeper you go, the more it'll work.
Is that what they thought? Is that what's up?
I'm guessing. I'm guessing based on everything I read. So the insulin coma units, this is a good thing actually. So remember lobotomies, how the guy was like, I can just do it in this hotel room, no biggie, right?
Right. Yeah.
Right. Very unclean.
Yeah.
During this, they were very clean. The environment was similar to that of an operating room. It was tightly controlled, lots of staff. So, I mean, at least they did recognize it was a dangerous type of thing. Because lobotomy is, let's just put an ice pick in your eye. It's fine if there's germs around. It's totally fine. Who needs gloves? So during the course of the procedure, regular physical and neurological tests would be carried out. So remember, the procedure wasn't just that one time. So they would continue to do these neurological tests in between the comas because it was going on for months. And then if there were concerns about the patient's safety, staff could terminate the coma early by giving the sugary drink via a nasogastric tube. So, nosy-posy, yeah. Or by IV injection of 33% glucose solution.
So if they felt like the person was too deep in a coma, or was maybe like
about to die,
not really breathing or something,
something like that, they try and bring them back out.
Yikes!
Yeah. After being given the procedure in the morning, the patient would then be expected to participate in occupational therapy and recreational activities in the afternoon. Hey, you've just been in a coma. You want to go run around? So some patients experienced as many as 50 or 60 episodes of unconsciousness.
Oh my gosh.
Yeah. So immediately following the injection, patients exhibited a range of symptoms. Shocking. Including, I always say this word wrong, even though I know what it is. So pallor, sweating, restlessness, followed by a deep sleep into the coma. There was constant monitoring by nursing staff. Following the completion of the full course of therapy, patients were obese, owing to the effect of repeated glucose injections.
Wow.
Yeah. Many patients also developed, this will shock you here, brain damage.
No.
Yeah. However, just like with lobotomies, that was perceived a lot of times as an improvement.
As being favorable.
Yeah.
Sure.
Yeah. Treatment also sometimes resulted in death. Estimates of fatality rate of insulin shock therapy vary from about 1 to 5%. So it was a low rate reported related to, who knows for real.
Yeah, exactly.
But I feel like that's still a really high rate for a procedure that you're doing. Insulin shock therapy was considered to be highly effective treatment for schizophrenia. In many cases, schizophrenic patients were selected for therapy because they were considered to be so ill that any change in their mental state, including changes that today are considered hallmarks of brain damage, could be claimed as an improvement. So basically, it almost seems to me like when you come out of this coma, are you easier to handle?
Yeah, that's bottom line.
Yeah.
Yeah.
Are you easier to handle? Doesn't matter if now you have the brain ability of a 2-year-old, you're easier to handle.
Yeah, it doesn't matter if that's actually the effects of
Mhm.
losing some brain functioning, as long as it.
Yeah, exactly.
Wow.
So critics of psychiatry suggest that if insulin coma treatment is not a torture, nothing is. That's
Yeah.
actually a quote.
Yeah.
And they talk about how devastating and painful it was for those who had to endure it. It's highly invasive.
Yeah, it's terrible.
Yeah. So Harold Bourne, one of the psychiatrists back in the 50s, he said, quote, "It meant that psychiatrists had something to do. It made them feel like real doctors instead of just institutional attendants." Because if you think about it, back in the 50s, talk therapy wasn't a big thing yet. It was just, it was a baby.
So it was popular because of the supposedly favorable outcomes, but also because psychiatrists liked to be able to administer.
Yeah.
Okay.
They felt like real doctors, I guess.
Very strange.
It is. So Bourne wrote a paper called The Insulin Myth in 1953, which was calling this treatment, like just calling it straight out a fraud. Like it's not a thing.
Mm-hmm.
And there was such a huge debate. Like I had so much research on this person said this and this person said that, like good and bad. And so I did pick out a few that I was like, I really like this quote, but it was so controversial. Like when I did the research for lobotomies, there's a little bit of controversy, but for the most part, everybody agreed it was really good until everyone agreed it was really bad.
Right.
Here is like straight from the get-go. There was so much controversy between the two sides of good and
Dissenting.
bad. Yeah. So there was an editorial published in the British Medical Journal in 1938. So this is like 15 years before Bourne's paper calling it all out, that argued the treatment was most effective if given early in the course of the condition, and suggested the need for additional training to enable medical staff to recognize those symptoms earlier. So they were like at the beginning in the 1930s, a lot of the media was trying to say it's so good, early treatment, this is perfect. And then some psychiatrists were coming out, and like I said, Bourne's was in 53 saying, no.
Mm-hmm.
They're bad, it's bad. No. This was a really interesting quote. So this is a description of insulin coma therapy that was published in the British Journal in 1937. So as they're saying it's great as a early treatment, this is what they say. So quote, "Within about half an hour, he becomes restless, tossing from side to side, at first moaning and later crying out. Furor may have set in. He leaps up in bed, staring and crying out loud. He throws himself about violently and has the appearance of maniacally resisting a great fear. He froths at the mouth, and his pupils dilate. He may beat his head and hands and feet frantically. Coma follows, and the patient lies shrunken into his bed, profoundly collapsed with a diminished pulse. He salivates profusely and must be laid on his side to allow the saliva to run out. From time to time, he may be convulsed. Occasionally, a true epileptic fit may be seen with epileptic cry, a tonic strait with cyanosis, and a clonic stage.
Wow.
Right? Like, that does not sound like something I'd want to put a family member through.
Nope. I don't think I can watch that.
No. Another psychiatrist described it as a very drastic treatment. The patient brought to the jaws of death many times. Mm-hmm. So in 1956, there was an article in the American Journal of Psychiatry that proposed that insulin coma therapy worked by bringing out about irreversible changes to the frontal temporal lobe, right where they do the lobotomy. So everything was all about that frontal lobe, right? The idea was that it was effective due to the endocrinological factors, the pituitary gland, our hormones, like everything everyone thought at that time, like even because this is in the time of lobotomies too, they're same time frame. Everybody was thinking it was that frontal lobe that controlled your mental illness. So yeah, they either loved it or hated it. There was, like I said, so much research on that. So I have a few examples. Here are the examples of doctors that were pushing it as treatment. This is great treatment. Sakel, obviously the one that came up with it. So he claimed that 88% of his first group of over 100 patients with the recent onset of schizophrenia showed a good degree of improvement with it. 70% making a full recovery. I don't know what that recovery would look like.
Yeah, right? Like how are they defining these terms?
Exactly. The following year, Easton conducted a comparative study in Canada this time. We don't have to find these in Canada.
Yeah.
He reported that 65% of patients who received insulin treatment recovered, compared with only 40% of those who were treated in the same unit but did not receive insulin. Again, what's your true basis of comparison?
Define your terms.
Right? Define what recovered looks like.
Yeah.
Because if recovered simply means you're easier to handle, I don't know.
Right.
So he said, quote, "In insulin, we have a drug by means of which we can alter the clinical picture in schizophrenia." Cool, right?
Okay.
Cool. Johnson, in 1939, published another large study in Canada again. So apparently we loved insulin here. He had 108 patients undergo the insulin coma therapy between 37 and 38, like 1937. And 322 patients treated at the same hospital between 32 and 36 before insulin coma therapy. So they're comparing those two time frames, pre and post. 82% of patients who had insulin coma therapy were discharged versus the 47% of patients from that earlier period. Again, if you are causing severe brain damage to all of them, the goal at that time, as we've seen in other episodes, was to make them easier to handle.
Yeah, not necessarily a fully functioning person.
And then McConnell in 1945 published another paper citing an 88% discharge rate among the insulin-treated patients. This was in Britain, compared to 48% among those who did not. So, I mean, based on what they're comparing their things to, it seems like a pretty high rate.
Sounds like successful,
right?
Whatever, yeah.
So let's talk about the ones that were against it. So these guys against it, we have Libertson in 41. So we're talking New York State in the U.S. Treatment of 330 patients found no difference in rates of improvement or recovery.
That sounds more truthful to me, yeah.
We have Teitelbaum et al., and others, in 46, reported the results of a controlled trial in the USA. Important in that spot because none of the other ones were controlled studies. So comparing insulin coma therapy and a barbiturate-induced coma, a placebo procedure, and general care. So they actually had a few different things they were comparing. And they found little difference between the procedures and concluded that improvement was independent of the treatment. Then we have Palmer, Rippenhoff, and Hanahan in 1950 described the outcome of a series of 393 patients in the U.S. who had received coma therapy. 34% were discharged. 6% showed a full recovery at follow-up, which was about 3 and a bit years later.
Mm-hmm.
And that's the only time that I saw a follow-up to it.
Something sort of longitudinal.
Right? So they're saying 34% were okay, but 3 years later, it was only 6%.
Yeah.
So they concluded that insulin was, quote, certainly not sufficient as a sole form of treatment in schizophrenia. So Freudenberg in 1947 says, quote, the difficulties in evaluating the effectiveness of this method. So here's where, remember I said that control group was so important. So Freudenberg goes on to explain that one of the problems of identifying the appropriate, is this actually working, is there was trouble identifying the appropriate control group and the comparative group, and the variations in the quality and the duration of the improvement. The fact that enthusiastic therapists, that's his words, might discharge patients earlier than they would have done otherwise, and that will skew the results.
Sure.
So there was a lot of critique, like I said, on this. They're saying that, all of these studies that are saying it's so good, they involve a very small number of patients. There was no comparative group, really. Even the studies that said, oh yeah, we compared it, not really. They were definitely not blinded studies. And there was no, and this is the biggest one here, and we've talked about this a lot, no standardized definition of schizophrenia or what recovery looks like.
Right.
How can you say they recovered when you don't actually have a baseline?
They had no rigorous methodology.
Again, I'm bringing it back to, I think it all comes down to they're easier to handle afterwards.
Yes.
Because we gave them brain damage.
Yes.
Yeah.
Wow.
Yep. So Richard Hunter, another psychiatrist from London, suggested that, so I talked about Bourne before, Bourne was against it, suggests that his commentary on the use of insulin in schizophrenia demonstrates how, and this is a quote, how easily irrational therapies are introduced, how readily they are accepted, and how hard they die. I thought that was an amazing quote because, there's so many of these treatments people get on. They even nowadays with weight loss, right? You hear this, oh, this is going to be the best thing. You have to, and everybody jumps on it. It's a crazy thing. And then it turns out, oh, that's not going to work.
Right. It's crazy.
But when you're inducing coma on people and literally giving them brain damage, come on. So it really starts the movement towards evidence-based medicine, though. Because people are calling out how poorly these studies are done and that there's no comparative and all that stuff, it really is the trigger to say we need actual evidence here. Come on. It was the first therapy to be rejected on the basis of randomized controlled trials in 1950. Others have described insulin coma therapy in its time as being effective and scientific for mental illness. Again, what was considered scientific back then is very different than now. So we do kind of have to put it in perspective, right? They didn't have, around this time, they didn't have the medications we had now. They didn't have talk therapy now. They were really trying to do the best that they could. Not saying that it was good what they did. It was horrific, just randomly putting people into comas or lobotomizing them against their will, as we've talked about. And I'm sure this was against people's will too. I didn't find any direct quotes like I did before, but I'm sure people weren't hook me up to insulin, give me comas. There's just no way.
If these people were institutionalized, already institutionalized, so they probably had no choice.
Exactly, right? So, I mean,
wow. Wow.
Aren't we glad we're not in the 50s? So antipsychotic drugs were starting to be introduced in the 50s, and that was why a lot of these other treatments were dying out, because they had another much less invasive solution.
Yeah.
And a much more helpful solution, one that actually gave results.
That actually worked.
Right.
Yeah.
The approach was largely discredited by the 60s and was no longer used. By the late 60s, the treatment had been abandoned, although there were some reports that continued to be used in Australia as late as 1974.
Yikes.
And in China, 1985.
No.
Right? That's That is insane.
Human experimentation.
Yeah, right?
Mhm.
So normally I already have a question prepared, but I didn't this time. My bad. But my question to you is, I'm going to think of it on the fly here. So
All
I'm
right.
just going to talk until it actually pops into my
Don't
head.
make it too difficult. Not too skill testing, please.
Which now this is going to be weird because obviously you would pick neither. But we have now talked about lobotomies and insulin shock therapy. They were the treatments of the time, like at the same time, they were the ones. Which one would you pick?
If I had a
Like
choice, if
you
they said
had
you
to
have to
pick.
choose one of these,
You have to pick or you die.
holy shit! Probably the not picking my brain.
Right? I know they're both absolutely
They're
horrific.
both terrible, but I probably would be horrified at the thought of something going through my eyeball.
Right? Me too, because they didn't put you out for that either. I know. I'd probably go with the insulin too. Again, both options are bad.
Horrifying as that is, yeah.
But looking at the two treatments that were at the same time, if you had a choice between them, because this was the only methods available to you, it's messed up. It is messed up.
It's horrifying.
Yeah. But yeah, I had a lot of fun researching that because I had never heard of it before. Never, ever.
That's interesting as hell.
Right?
Wow.
So yeah, I hope everybody enjoyed that. Because I definitely learned a ton. I said to Renata, I was texting her, I'm like, oh my gosh, there's so much about this. And it's shocking that there's so much about it and we didn't know anything about it.
No, like not at all.
No, never heard of it.
I mean, not that I like
I think
went to school for anything to do with
right,
psychology or psychiatry or
well, I did, and I never heard of it.
I don't even remember ever reading about it or hearing about it.
And I think it has to do with because again, lobotomies and insulin shock were at the same time. Lobotomies are just, this is going to sound stupid, but it's the sexy treatment. Like it's more entertaining to watch that for like TV shows and stuff that are trying to introduce these archaic ways of helping people. That is a much more entertaining thing to watch than putting somebody into a coma.
Yeah, true.
So thanks for joining.
Thank you.
If you have any suggestions on a topic that you are interested in hearing, shoot a message down below, throw it in the description, let us know, because obviously we just pick stuff that we're interested in, but if you want to hear something more specific, let us know. And be sure to tune in on, why did my mouse go there? And be sure to tune in next Wednesday, 9:30 a.m. Eastern time for another episode of the Write or Die show. Trisha, I think, is on. I think it's a Trisha Copeland. She is coming on the show, and we're going to have, of course, lots of fun talking about mental health as always. And then join us next time here on the Bedlam podcast so you can hear all about some crazy stuff that happened in the past. How did we get to where we are now?
Right.
Yeah. Okay.
Thank you.
Bye.
Bye.